So we're going to talk about the techniques and tips for the removal of the enucleated tissue. Okay?
Okay.
No disclosure as we talk about it. The scheme of the talk, we're gonna talk about history, how far are we, explanatory videos, some comparative studies, management of the hard nodules, other alternatives for if anything breaks, and talking about a little bit of new prototypes. Okay, so this is what we talk about in the past talk. Okay, the first surgery with laser was in 1986 with a neodymium jack laser with low frequency and low power, having slow coagulative necrosis. Okay, so the problem was that the patient had to remain with a catheter for a long time while the tissue was reduced and expelled the clots in the catheter. But even though those complaints, it was better than turp because they used saline water, not the other water. Okay. The first machine that they used was this one that we just discussed earlier, the tulip, using coagulative necrosis and with just ultrasound view. Okay. And the problem was the size of the necrosis was very high. And the penetration of the laser was long. Okay, was very deep. So I wanted for you to see this. These are two examples for the bipolep and monolep. Okay, at first I resected all the median lobe, and then I pushed to the side the left lobe to see the capsule. This was a surgery that we did in the hospital when we doesn't have any laser, and it was for the best for the patient because we saw that even with bipolar energy you can do it as well. The main strategy that you need is to enucleate the apex of the prostate. Is the toughest one that get again enlarged with the time. And if you enucleate it, you're going to be very sure that that tissue it's not going to grow back again. Okay, so this is just for you to see that you can see the capsule even though we don't have a laser. So we had all the wall of the prostate removed. If you see a little bit vessel, you can coagulate it with the bipolar energy. And when you have it all enucleated, just grab from the up of the prostate, then you cut it. That calls the mushroom technique. Okay, and this is just if everything fails and you just have bipolar, you can do it and you can resect all of that tissue and the patient is going to be out of the OR like this. Very, very clear. This was another patient with prostate cancer that we did the same with monopolar energy. So at first, well, you have to be very sure that you're not getting a lot of strength to the capsule because the worst thing that could happen is to tear the capsule, okay, or to perforate the capsule. But well, in this case, everything was okay. And if you see it, it's the same principle. So, but with bipolar energy or tulip energy or green laser energy, you're gonna be having more mechanical removal of the tissue, and that for gonna translate of more incontinence rate. But even with that kind of energy, you can finish your surgery and with little blood loss. Okay. So the first cases with morcellator, we just discussed that in the past class. It was in 1998. Initially, the enucleated tissue was resected with bipolar loop, which made the procedure slow and more expensive because there was more time in the war. And the morcellator began with a knee endoshaver through a suprapubic puncture. We just today saw a surgery in the next OR that we were making the circumcision, and they were having a knee surgery. And I told Jorge to take a look of the endoshaver, and it's the same apparatus. It looks very similar, okay? So this was the first morcellator. It was introduced with an 26 French channel through a working channel of a nephroscope that we just discussed earlier. And the types of morcellator techniques. We're gonna see the two most common used types of morcellator. This first one is the Versaclut one. The brand is Lumenis and it's Versaclut, okay? So this is the thing that you grab with your hand, and this is the shapes of the morcellator. So the first thing that you have to be sure is to see good water without any clots or actual bleeding. So you have to be sure that it's clear, the water, to see more. So right now we are seeing the morcellator tissue, and in this case, the nucleated tissue was up and the shapes were stuck. But you can do it all around or sides. It's not a problem. Even you can take it that nucleated tissue and go to the faucet, make the morcellator there. And you have to be very patient with slow suction and slow shapes, because if you push a lot or very fast plates, you're gonna lose the tissue, and that's gonna be more time, and you're gonna be more tired. So be patient. It's the last step of the surgery, so you have to be patient. So those are the little beach balls. You have to be more patient with the beach balls because they are rough and very tough to get out. But if you do it slowly, you can morcellate it. You have to have a good blades, because if they are very used, they're not gonna be very yes. And these are the two main techniques, with the enucleated up or enucleated down, but it's the same. Then the down ways was an article that some Japanese were talking about. They said that it was safer, but I think whatever you please, but do it always the same way. Yeah, I prefer with a up. Yeah. And the other one is the piranha, the wolf piranha. We have all the blades, the little lever to on and off, and the difference is that it rotates inside of the outside of the blade. You have two models, one that gives you the revolutions and the other that gives you the suction, and you have a pedal with suction, just suction, and the mode piranha. The mode piranha does the most as well. And as well as the other, you have to be able to see more and to see best and to have no bleeding at that time. What we will do, if there's clots, you can get out all the nephroscope and let all the clots go out. That's a thing. The other thing that you have to be sure it's everything is going okay, that everything is in the procedure it's on. That's the prostate, okay, and you start the morcellation like that, okay. You have to see the little wall. That's the best parameter to see how far or close to the lens you have to be. But the best thing is to see the wall. And if you are having problem with the vision, you have to be sure that it's not bleeding actually in the morcellation time. If it is, you can put a catheter and make a washing in the bladder and then make again. What to do if there's no suction? Well, you have to check out that everything is going okay, that you have suction power in the other thing, and restart the suction. If it's not working, you can put water the other way that the suction, or put the suction to the other way, because sometimes we have, and you can get that piece to see there's no any little piece of the morcellated tissue, because sometimes we have tissue that it's very hard and get stuck in the tube. So just yeah, flush it the other way, or put the suction in the other way to get that out. We have seen that a lot. Okay. The other thing that you can see is when you grab a little piece of bladder. So why does they could appear that? Because if you're not seeing well, and it's blood in the bladder, if you get very near to the bladder, you can grab it. And it sounds different. The morcellator sounds different, and you're gonna feel that in your hand. Okay, so when you have that, the first that you have to do is get out of the feet of the pedal and be sure what is going on. If you're not seeing well, you can get in the bipolar or the laser, or get out all the clots. But the first thing that you have to do, it's not to take it like this.
Yeah, stop and
Yeah, and try to do it slowly to deattach the bladder, the mucosa bladder, okay? Because if you get scared and get all the equipment out, you're gonna take a big bite of the tissue. So first of all, stop the suction, then try to detach the bladder mucosa, and then see what happens. Even though if you have a bladder perforation, if it sits in the bottom of the bladder, it's not a problem. You just with a catheter, it's gonna be okay. If it's in the top of the bladder, that's not a problem also. If you have it in the back of the bladder, well, that could be a problem, but it's not very often. So just try to see well, okay? And do it slowly, okay? We're gonna take that talk about the complications and how to repair that or how to act, but those could be the main tips, okay? Okay, and the device comparisons with Piranha and Versacut, it's supposed in ex vivo or in the lab studies that the Versacut suction power is 22.2 milliliters per second, and the irrigation is 0.5 milliliters per minute. So half a liter in 1 minute. It's a lot of irrigation. And the morcellation power, it's supposed to be 6 grams per minute. It's a lot, 6 grams. So if you can reach that, you're gonna end very, very fast. But in real life, the morcellation rate, it's like 2.23 grams per minute, more or less. It depends all in the prostate. If the prostate has more zones that are hypoxic, you're gonna be seeing more tough tissue, and you're gonna be longer in the morcellation time. Okay. So well, but in laboratory, these are their numbers, and the Piranha, the aspiration was 20.4, the irrigation was lower, 0.3, and the morcellation 2.5 grams. but it's better control of the suction by the handpiece because you have that lever there and you have less visualization flow. Okay, these are the comparative of the visualization. The first circle, it's supposed to be wolf, and the second circle, it's supposed to be stores. So yes, you have a better visualization with stores, but in the laboratory, okay? So they did an in vivo multi-center comparison with real cases and real prostates, and they show no significant difference between the two of them. So the following steps for the best morcellation rate, you have to complete the resect lobe as usually, and you have to be sure if it's soft, it's going to be easy to suck and easy to morcellate. If the surface of the prostate is with firmness tissue, it's going to be difficult. And if you see it very compact, the morcellator, the tissue, you're gonna maybe sometimes you have to do a little cuts with a bipolar loop to do an irregular surface and let the morcellator blades take more suction and be more with more efficiency the morcellation. Okay, easier to grab with the blades. Okay, so if you see that rough face and dig several holes in 30 seconds to a minute by a laser, do some in Germany. What they do before they get all the prostate to the bladder, they do some channels to the adenoma before they put it all in the bladder, because if it's irregular, it's easier to the blades to grab it and suction it and morcellate it. Okay, so if they say that if it's tough, you do the inverse technique, and if it's soft, the upward technique. But it doesn't have to be written in stone. If you see it, whatever you feel comfortable with. Okay. If it's moderate on small glands with firmness tissue residual, it's going to be difficult to suck because it's going to be more dense in the tissue. So you can make some channels with a laser or take out by a clamp. What we talk about with the clamp that we saw in the equipment. Okay, and be sure to empty all the bladder at last to see if there's no little pieces swimming in there, and take the camera to the fossa, because many times you get little pieces in the fossa that you cannot see as well, because at last that what you want is to finish and put the catheter. So be patient, go to the fossa, start looking in the fossa. Okay. Well, hard nodules, also known as beach balls. It implies more morcellation time due to difficulty or taking the tissue or morcellating, and it's a pathological component, and its main predisposing factor were studies in this study. Okay, and they saw that patients older than 65 years old had more beach balls. The morcellation volume more than 65 centimeters were more likely to have hard nodules, and the higher PCA were more likely to have nodules. So what they did in these cases, they grabbed the clamp and they grabbed all the beach balls and get it out as one piece. But you can do it with blades. If you trust your blades and you have few surgeries with your blades, just be calm and take it slowly, okay? But if it are hard like this, or your blades are no more are old or something like that, you can grab it with the grasp and take it out, or with this loop. This is a special loop for that. But if you don't have that loop, with a grasp you can do it without a problem. Okay. So They review the histopathological content of the heart nodules, and they used Masson trichrome to determine the extensive amount of fibrotic tissue, and among the possibilities to the phenomenon implication of chronic ischemia in tissue, as confirmed by the Berget and collaboratories study. There was a study that they said that the patients with hypoxia in the pelvis are more hard prostates because they don't have a good blood flow. Yeah. And you're gonna be seeing more beach balls in those patients. So what you're seeing right now, it's more fibrotic tissue in those patients, okay? Like this one. This is the trichromo Masson technique. So if you compare new blades or used ones, it's gonna be always better new ones. It's supposed a new prototype, it's gonna be, you can throw it out at the first surgery. I don't know when it's gonna be out. Disposable. Yeah, but I think it's gonna be more expensive because every time you have to buy a new one. But maybe in a insurance kind of patients, it could be feasible, okay? But I don't know about the contamination rates and all of that problems. Here in Latin America, we try to use it the more that we can.
Even with us in the social hospital, the disposable, we clean it.
Yeah, sometimes.
Yeah, because sometimes the patient doesn't have money and you have to help.
Yes. Yeah, it's the problem with the public medicine. But yeah, if you can offer the public patient more and the best, it's the best that you can do. Okay. Well, what to do if there's you don't have a morcellator or if it's broken. So there were some studies. This one is a patient with
it's just suprapubic.
With a suprapubic, like a laparoscopic channel. Okay. Then they grab the adenoma with in this suprapubic channel, and with a bipolar they
resect it.
Yes, they resect that.
I saw some doing the same.
Yes,
but with the bipolar, not the loop, the vaporization, the bottom.
Okay, yeah.
Yeah, they make it like vaporizer. The same principle.
Yeah, and maybe at last you just grab that channel off, and with a catheter it's gonna be okay.
Yeah.
But well, this is you could do that, okay? You grab it like a piñata, and take like the bat and punch it over the prostate like a piñata, okay? The other way that you can do it, it's you morcellate you enoplate, sorry, all the prostate, you throw it to the bladder, and then you do a little incision, like a little fan steel incision. Well, if you have, in this case, they had diverticulum, big bladder stones, and a big adenoma. So I think it was for the best for the patient, because you have to resolve the diverticulum, and you cannot do it endoscopically. So, or if you have a lot of time of surgery, or if you don't have any more water, you can do that. Okay. And then close it and put the catheter. They compare the groups of the mini laparotomy, and they saw that all the EPSS and the QMAX were good, even with the open surgery. So that doesn't
difference between
not the difference if you have to open it or if you do it endoscopically. So it's better to finish all in the same surgery. Okay, but if you don't, if you can't, it's not the end of the world. Okay. Okay, so there was another study with a morcellation with pneumovesicum. It's putting air to the bladder and channel by a laparoscopic tunnel. And they compared the study with Versacut, with traditional Versacut versus the morcellation with trocar and pneumovesicle. The prostate morcellation time was 70 grams, and in pneumovesicum was 7.8 minutes, and for the Versacut 34 minutes. So it's faster to do the morcellation with an laparoscopic morcellator, but well, but the thing is that you have to bring a hole.
Yeah, put a trocar.
Put a trocar.
The bladder from the suprapubic.
But you can see it in a view, in an endoscopic view, and see that you're not any lesions of the bladder. So it's, well, if you just have that, you can use that, but if you have the Versacut,
No, but if you open for the continue the opening and take it out.
Yeah,
It's the same.
yeah, but you can do that. It's recommended only if endoscopic morcellation is not
But it's
available.
not working here.
Okay. The other one is the ultrasound guide morcellation. It's an option in extraordinary cases of lack of visibility or when it is suspected you have an adenoma remain. So they have some problems with the camera, and what they do was an ultrasound, a live ultrasound, and they did the morcellation view in the ultrasound, because when they tried to see in the camera, they didn't see anything.
This is the same method as the aquablation. When the aquablation is with the ultrasound.
Yeah.
When you see it, the water vaporization like the morcellator when it comes in.
Okay. So it could be a thing. Okay. So there's a good question. If you morcellate the tissue, the rates of cancer, of prostate cancer, are going to be low or going to be the same?
The same.
It's going to be the same, but with the pathologist, what they prefer. So they did many works, multi-center works, and they saw that if you do with a green laser, you don't have any tissue. If you do it with aquablation, you don't have any tissue. If you do with Risum, you don't have any tissue. But if you do resect with bipolar or monopolar, it's better to morcellate, because when you hit all the gland, you're gonna miss a lot of cells, because it's gonna be dehydrated because of the heating of the loop.
Yeah.
Okay, so it's better to morcellate. It's best for them. They can see it more clearly, all the cells. And if you have a patient with prostate cancer, it's easier to them to make the diagnosis. Okay. The new prototypes, they used patients with open prostatectomy samples, where they put the prostate in boxes, the same boxes, and 2 commercial available morcellators and 2 prototypes were studied, and they compared the morcellation time with the different devices in a ex vivo kind and in laboratory, but with very similar stages. Okay, so I think that it's good to see this kind of ranges that you can manage with the morcellator, because in the Versacut line, if you do more rounds per second, you're gonna be losing more time of grams per minute. So if you do it faster, you're really doing slower.
Yeah.
Okay, because you're missing you don't leave time to the tissue to go into the blades to get cut. So if you want to be faster, you have to put it in slow suction and slow blades. Okay. And they compared all the devices, and they saw promising results. Yeah, there's a new prototype that it's just in study, Because the problem with the morcellation rates, if you want to do it very fast, maybe you have to increase the suction, and maybe you have to increase the blades. But that will be a problem too, because you
The
can,
risk of injuries.
you will have the mucosa of the bladder
Yeah.
near.
Because you suck all the water and the blade is bigger.
Yeah, and the chances of have a problem is gonna be
Yeah.
higher. So maybe the old school is the best, do it slowly, but
Mm.
with calm and with low volume of suction and low rates of morcellation, and that's gonna be best. Okay, it's gonna be better that way. So as we talked the last master class, it's fine to celebrate the success, but it's more important to hit the lesson of failure when we talk about it. Okay, so thank you for listening.
Manchester.
Muy bien.